Very good morning, and before I start, I must say that it's an honor to be part of the 3D Con, and not just an honor, also congratulations to Sir Vijayakumar Sir and Rajesh and Gauri Shankar and the entire team of 3D Con. And also an honor to invite everybody from all over India for this prestigious event. Sir actually called me, Vijayakumar sir called me and said, you are part of a Jugalbandi. So I said, sir, what is a Jugalbandi? He said, you come and you will see, I'll show you what it is. So I called Vijayakumar sir, and of course, before I move on to the so-called Jugalbandi, I should also say it's an honor to be sharing this so-called Jugalbandi with none other than my teacher, Vijayakumar sir, who, I still remember the way that my memory of my UG days, medicine is very few. I can count the number of people who have had an impact in my medicine and my interest for medicine and pursuing MD medicine, of course, by default. But the inspiration was from people like you, sir. Thank you.
So it's a teacher-student Jugalbandi.
Yes, it is a teacher-student Jugalbandi. Thank you. So, yes, this is the opening session, and it's none other than the Jugalbandi on the role of diet and physical activity in the management of diabetes. And I think it's very, very apt that Vijayakumar sir has chosen this topic for the important session, because I think as clinicians, quite often we underestimate the importance of lifestyle modification. Very often, especially in the busy clinic when we are sitting, we focus so much on the numbers, the labs, or the HbA1c and the fasting and the postprandial, and we focus so much on which agent, which pharmaceutical agent or which drug to add next. Quite often we neglect the importance of lifestyle modification. Quite often we forget to ask the patient also whether there is any changes in their physical activity, whether they are actually complying to their lifestyle changes. So it's pretty apt that this is the first session. I'm going to be focusing on the importance of diet, the first part, and then I will hand it over to Kumar sir to take it over on physical activity. So I found this picture very, very apt to start off with. It's just something to show us the importance of the evolution of the diet, of how overall, when we initially, our ancestors, as you can see, I think this is the pointer. Yes. As you can see, we started off as monkeys, as we all know, and now we are all turning out to be pigs. So as you can see, from lean mass, how now this is the current scenario where we've all become couch potatoes. And earlier, the whole point of eating was for survival, right? The human race had to actually hunt for their prey and to go hunting for food. But now everything is delivered to us at the click of a button. We have Swiggy and Zomato and whatnot. And our children, even if there is dosa and idli and upma at home, they want a burger which can be ordered the next instant, isn't it? So literally from monkeys, we are now turning out to be pigs, and that is the sad story of our diet today. And there is a huge mismatch between calorie consumption and calorie expenditure. This is due to urbanization, westernization of diet, lower physical activity, and I'm going to show you data to sort of show you the data in our part of the world as well. And as you can see, this mismatch is what is leading to all the burden of the metabolic disorders that we are facing today, including type 2 diabetes, non-alcoholic or NASH, obesity, systemic hypertension, dyslipidemia, cardiovascular disease. So we have recently we had published data from our own South India, in which we wanted to go back and look at the trend of metabolic factors, including type 2 diabetes, dyslipidemia, obesity, and so on, in our own part of the world, in Tamil Nadu itself. So we had last published data in 2006, and 10 years later, went back to the same areas to look at or to assess if there is in fact an increase in the trend of these same risk factors. So the three populations that we had studied earlier was Chennai, to represent urban population, Kanchipuram, which was a town, and Pandruti, which was a village. And the results in fact showed that in fact there is a significant rise or increase in the prevalence of type 2 diabetes, and there is in fact an increase not just in the urban but also in the rural population, and again not in men as we thought earlier, but also in women. Now this is interesting, but what is more interesting is this fact over here which I'm showing in front of you. We found that there is in fact an increase in the prevalence of type 2 diabetes, but what were the factors that were contributing, the significant factors that stood out in this population, in our own Tamil Nadu, that is contributing to this risk? And when that was further assessed, of course, positive family history and age did come out, but those are non-modifiable risk factors. Furthermore, we found that the waist circumference was one of the most important, significant, independent risk variable that was contributing to an increased risk of type 2 diabetes. Again, not just in the city, but also in the town and in the village. And when you see, this is something that I really want, which I think will be very relevant to Sir's talk when we hear from Kumar Sir about the importance of physical activity, you can see that there is a significant drop in physical activity levels in the rural population. So in the villages, physical activity has significantly come down, and that in turn is contributing to an increased prevalence of type 2 diabetes. Furthermore, we also looked at the changes in dietary habits over a period of 10 years, again in Chennai and Pandruti, and we found there is a significant increase in the total calorie consumption. As you can see, this is statistically significant. Even in the village from 1800 to 2020, from 2022 to 2210, all these are statistically significant. Significant increase in total number of calories, a significant increase in the carbohydrate consumption, significant increase in fat consumption, and overall also in protein. So a huge people are basically eating a lot more than 10 years ago. And this is contributing to the increase in prevalence of type 2 diabetes. Furthermore, when you look at the prevalence of obesity, again comparing the same urban and rural areas, and this is over the years from 1980s, this is data that we published in early 1980s by my father, and 1980s where it was a small 16%, a mere 2% was the obesity prevalence in the rural, same Pandruti in 1992. And in 2016, from 2%, an explosion to almost 50% is the prevalence of obesity in the same population, the same population that we had looked at years ago. Furthermore, when we assessed the type of obesity, it is not just by definition of BMI. Yes, there is a significant increase in the BMI as well, but also a significant, like I showed you, increase in the abdominal obesity as well. So, what do the guidelines say? What do we do? Now we know that dietary habits have changed. We know that that is significantly contributing to increase in cardiovascular risk factors, including type 2 diabetes, obesity, abdominal obesity. We know that people are eating more, people are eating unhealthy in our part of the world, not just in the city, but also in the rural population. What are the guidelines saying, and what are we supposed to do about this? Now, over the years, the guidelines for dietary habits have also evolved. We also always talk about how the guidelines for management of type 2 diabetes has evolved over the years. Similarly, how we've moved from a glucose-centric approach to a more patient-centric approach, or an individualized approach today. Before, the dietary guidelines were very sort of flat and one rule fits all. Carbohydrate 50%, protein 20%, and fat 20% or 30% was the guideline, which was one rule fits all. But now the guidelines have actually been evolving, and today, again, diet is about individualizing the care of patients with type 2 diabetes. And this is the recent guidelines from 2024 ADA guidelines. And they say that it's more about the quality of the nutrition, the macronutrient distribution, and furthermore to personalize not just management of type 2 diabetes in terms of drugs, but also personalize our dietary care and dietary prescription for patients. So what are the factors to take into consideration? Of course, this is more the role of the nutritionist or the dietitian, but as clinicians we should have some awareness about this, some idea about what are the factors that are important when we take the diet into consideration for patients. It is of course the age of the patient. We have to take into consideration the comorbidities, including the renal status, the liver status, the cardiac status, because the fluid intake and the amount of protein to be prescribed would also be important. the body mass index or the body fat distribution of the patient. For example, patients with sarcopenia and older age, we probably want to increase their protein intake, or even younger people with sarcopenia, where the goal of therapy is also important. So if we want weight loss, calorie restriction, if we want whatever is the goal of therapy. Last but not the least, the social and the economic status of the patient is also very, very important. So we cannot be sitting in our clinic and telling a Miss Kupusami or a Mr. Kupusami to take, from tomorrow, take millets or take quinoa. It's not affordable. It's not even easily available. We have to take into consideration the cultural background of the patient and the economic status of the patient and see what their cooking sort of habits are, what is the environment, the family support that the patient has. Various factors are very, very important when it comes to diet. So all these put together is important for quality and personalizing dietary care. So the basic concepts of the dietary recommendations are to minimize or avoid added sugars and refined grains, increase non-starchy vegetables, opt for whole foods and avoid processed foods. These are the basic principles that the guidelines recommend. When we look at carbohydrates as such, the RSSDI guidelines and the ICMR in general recommend carbohydrates of 50 to 60%. ADA does not have specific guidelines but says to individualize therapy. But overall, the key takeaways from most of the recent guidelines is to reduce overall carbohydrate, refrain from refined carbohydrates, take overall nutrient-dense carbohydrates, high fiber carbohydrates with low glycemic index and load. When it comes to proteins, again the RSSDI guideline says around 15% of proteins, ICMR 12 to 15% of protein in the overall diet of people with type 2 diabetes. ADA again says to promote according to the patient needs. But overall, the key takeaway is to focus on quality more than quantity of protein and again to individualize therapy. But the importance of protein is to promote satiety and to prevent sarcopenia. And of course, protein, we have to take into consideration the renal status of the patient as well. When it comes to fats, less than 30%, RSSDI, ICMR says 20 to 30%, ADA again says to individualize, but overall, avoid the saturated fats, more of the polyunsaturated fats, and avoid reheating, refrying, focus on quality more than quantity. I didn't go into too much of details on these because I thought this is more of a nutritionist scope, but as clinicians, it's important to know to have an overall idea. Very important topic. This is very, very commonly debated and discussed, and a lot of recent highlight on this. Artificial sweeteners. A lot of patients also ask us about this. Even if they hear from the dietitian and they come to us, they want to hear what the doctor's point of view is. So yes, there was a warning recently, but that is only when taken in very large quantities. So the WHO has actually recommended that they are safe, can be taken in small quantities with their beverages on a daily basis. There is a recommended daily allowance for each of these. And sucralose and stevia or stevioside are the safer ones, which are even approved in children and during pregnancy. Now, of course, moving on to just the last bit of my presentation, which is about the various diet patterns. We know about the Mediterranean diet, the very low calorie diet, the vegan diet, the intermittent fasting, all these newer diets that have come into play, and patients do ask us about this as well. We know the famous direct trial which showed that there is almost 50% remission of type 2 diabetes through a very low calorie diet, and probably very unrealistic in the real world, but they have anyway proven results with this. And this is a meta-analysis in which they've actually compared results from the various types, a very busy slide, but various types of trials which have actually been studied: the low-calorie diet, the low glycemic index diet, vegan diet, Mediterranean diet, which has gained a lot of popularity, vegetarian diet. All these, some of them have shown, there's mixed results, some have shown non-significant, most of them have shown some significance in terms of, but the overall principle is that most of these diets, there's either calorie restriction or in terms of intermittent fasting, there is the autophagy, the switch from glucose to fat as a fuel, and various concepts based on these diets. But whichever the diet, whichever we prescribe to patients, whether it's this diet or that diet or whatever calorie restriction or whatever protein or fat, the most important factor to keep in mind is that change in behavior doesn't happen overnight. And when we tell our patients, just telling them in the first visit and then ignoring it after that does not work. Compliance to this is what is most important, and adherence to dietary changes and lifestyle changes is the biggest challenge. And what we have found is that this is our most popular, the SMS study, in which we found that there was a significant reduction in the incidence of type 2 diabetes in people with pre-diabetes. SMS, simple text messages, actually help patients adhere better to lifestyle modification, and thus there was a 40% reduction in the incidence of type 2 diabetes. That is the background of this study. But what this slide shows you here is that in the same study, we found that with just a simple tool like text messages that reminded patients to adhere to their lifestyle changes, the dietary calorie intake was a significant drop by the end of the study at second year, and the adherence to the dietary energy intake and the adherence to, this is physical activity. I need to correct that there. This is dietary intake, and this is the physical activity adherence, which improved by 67% as compared to 52% at baseline. Furthermore, and this is what I need to want to, as you see, this is the post-trial follow-up of the study. So the study ended at the end of 2 years. Right? But we actually went back to the population 5 years down the line where patients were out of the study. And interestingly, we found that still those who were in the SMS arm, there was still compliance to behavior. The change in behavior continued even at the end of 5 years, although they were not part of the study still. Right? So that just comes to show that when there is a change in behavior for a prolonged period of time, it's probably more sustainable. Last slide, just to sort of talk about the future of nutritional therapy. Of course, we need to talk about, this is the world where we are now being run by AI. So this is just the concept of precision nutrition and genetic testing. As we know, one diet does not suit everyone. We know that some people, some of our friends get to eat everything and they don't put on weight. But some people just smell the food and they gain weight. Right? So that is the whole concept behind precision nutrition, where we know that diet and type 2 diabetes is extremely important. Diet, physical activity, medication is all important. And of course, you can assess diet through questionnaires, 24-hour recall, so all. But the so-called, and then you have the wearables, which also give you real-time data. But then genetic testing and further analysis to see what kind of diet will actually suit which patient is what is called the omics, or the future is basically what is called precision nutrition, to find out, just like pharmacogenomics, it is nutrition genomics, to actually tailor make prescriptions of diet for each patient, which is the future, which is probably 20 years down the line. Don't know when that's going to be, but that is the future of nutritional therapy. We'll now move on to Kumar sir to hear about physical activity. Thank you.
Thank you. And